Hello KJR readers, my name is Jiyoung, the first author of this study. Today I will present our study titled Long-Term Pulmonary Function and Radiologic Abnormalities up to 3 years after COVID-19, a systematic review and meta-analysis. As of now, over 750 million people worldwide have been infected with COVID-19 and around 7 million have died. Long COVID has been a major concern, with persistent pulmonary sequelae reported in up to 40% of community populations and as high as 93% in hospitalized patients. However, most of the evidence so far has focused on outcomes within the first year. Long-term data beyond 12 months on lung function and CT findings remain limited. Our objective was to systematically evaluate the long-term trajectory of pulmonary function and CT findings in COVID-19 survivors. We wanted to extend the follow-up period, looking at outcomes from 6 months up to 36 months. By integrating both PFT and CT data, we aimed to provide a more complete overview of pulmonary recovery. To achieve this, we performed a systematic review and meta-analysis following PRISMA guidelines. We systematically searched PubMed and Embase for studies published between January 2020 and June 2024, and we also manually reviewed references. We included studies reporting pulmonary function tests or chest CT findings at 6 months or longer after COVID-19 infection. We only included studies that include at least 20 patients, thereby excluding case series or simple case reports. We excluded meeting abstracts without detailed data, studies with unspecified follow-up periods, and non-English or retracted articles. For the statistical analysis, we conducted multivariate meta-analysis using linear mixed effects modeling. This approach allowed us to assess temporal trends across 6, 12, 24, and 36 months, while accounting for correlations within and between studies. Our search initially identified nearly 4,000 records. After duplicate removal and screening, 152 studies met our inclusion criteria. This included 133 studies reporting pulmonary function outcomes and 80 reporting chest CT findings. In total, we analyzed data from 25,766 patients. The mean age was about 57 years, and men accounted for 58% of the population. Among studies that reported smoking history, 31% were patients who have ever smoked. About 11% of patients had underlying chronic respiratory disease. When we look at pulmonary function, the mean percent predictive value of diffusion capacity was 81% at 6 months and increased gradually to 84% at 36 months. DLCO impairment was the most common lung function abnormality. It was present in 42% of patients at 66 months, and although the prevalence gradually decreased, it was still observed in about 35% even at 3 years after infection. For forced vital capacity, the mean percent predictive value rose from 95% at 6 months to 98% at 36 months. The prevalence of FVC impairment declined from 14% to 8%. Less than 10% of patients showed FEV1 to FVC ratio impairment at all time points without clear temporal trend. As shown in this trend graph, the mean predictive values of DLCO, FVC, total lung capacity, and forced expiratory volume in 1 second all improved significantly over time from 6 months to 36 months after COVID-19 infection. When we look at the prevalence of PFT impairment, the prevalence of DLCO and FVC impairment also decreased significantly during follow-up. By contrast, the prevalence of FEV1 to FVC impairment remained stable with no statistically significant temporal change. Taken together, these findings suggest progressive recovery in diffusion capacity and lung volumes, while obstructive physiology, as reflected by the FEV1 to FVC ratio, shows no meaningful trend. For chest CT findings, about 30% of patients showed no relevant CT abnormalities at 6 months follow-up. This prevalence remained relatively stable, around 30% to 40% through 36 months. Ground glass opacities were seen in 32% of patients at 6 months. This decreased gradually to about 20% at 36 months. Fibrotic changes were present in 29% of patients at 6 months. The prevalence of fibrotic changes on CT fluctuated, ranging between 27 and 47% up to 36 months. When we examine the trend lines, the prevalence of patients with no relevant CT findings appeared to increase over time, but this change was not statistically significant. The prevalence of ground glass opacities showed a significant decline over time, whereas fibrosis and other structural abnormalities persisted without resolution but also without progression. In conclusion, most COVID-19 survivors show significant improvement in lung function and ground glass opacity over 3 years after infection. However, about 1/3 continue to have impaired diffusion capacity beyond 3 years. Fibrotic changes persist but do not appear to progress. Ongoing monitoring and further research are needed to understand the long-term impact of these residual findings. Our study has several limitations. First, there was substantial heterogeneity across studies, including differences in patient populations, COVID-19 severity, and measurement methods. Second, selection bias may be present, as in some studies, follow-up examinations were performed only in symptomatic patients, which could have led to an overestimation of abnormalities. In addition, restricting the literature search to English language publications may have excluded relevant data. Third, definitions of CT and pulmonary function test abnormalities were inconsistent across studies. Finally, limited study-level data made unified categorization of fibrosis and severity quantification of CT findings impossible. Thank you for listening.